So hey guys, my name is Rishabh Singh, a first year medical student from Eastern Medical College and Hospital, Comilla. Welcome to my channel. If you're new here, so please go and subscribe to my YouTube channel. I try to provide you some educational video related to MBBS. I hope you will gain or acquire something new at the end of it. If you like, don't forget to subscribe, like and comment below. Welcome to my YouTube channel. Today's video is on thyroid gland and its development. So coming to today's topic, thyroid gland. Thyroid gland is highly vascular and ductless gland. Ductless means endocrine gland and highly vascular means the gland which is rich in blood flow. So now coming to location of thyroid gland, the thyroid gland is located in front and the sides of trachea or in the lower part of front and sides of the neck opposite to cervical 5, cervical 6, cervical 7 and thoracic 1 vertebra. And it is also known as largest endocrine gland in the human body. Now coming to the diagram of thyroid gland which will show the location of thyroid gland and the presenting parts of the thyroid gland. So this is the diagram of thyroid gland in which you can see the vertebral level from C5 to T1, and you can also see the lateral lobes of thyroid gland, isthmus, and you can see the pyramidal lobe which is connected to the hyoid bone by the levator glanduli thyroidi. You can see thyroid cartilage, cricoid cartilage, and the first tracheal ring and fifth tracheal ring in the diagram. Now coming to presenting parts of the thyroid gland. So these are the presenting parts of thyroid gland. Thyroid gland consists of two lateral lobes as shown above in the diagram, which consist of apex, base, anterior margin, posterior margin. Both the margins are basically representing two borders: anterior lateral surface, posterior lateral surface, and medial surface. These three represent three surfaces of thyroid gland. Now coming to special features of thyroid gland. The first feature will be it manufactures, stores and releases the hormone as required. It depends on the external environment for the raw material to manufacture its hormone. The third point will be it is an organ of body having a rich blood flow, that is, it is highly vascular organ. It is located superficially, so hence accessible for physical examination. So these are the special feature of thyroid gland. Now coming to function of thyroid gland. Before coming to function of thyroid gland, we know thyroid gland secrete three hormones: T3, T4 and calcitonin. Now they will have the certain function by which the growth and the BMR will be regulated. So the functions are regulation of BMR. BMR is basal metabolic rate, and temperature regulation also. It will also stimulate the psychosomatic growth of the human body, and it will play an important role in calcium metabolism. Basic role of the thyroid gland will be the growth of the body and the regulation of the BMR. Now coming to weight and dimension of the thyroid gland. So the weight of the thyroid gland is 25 gram. Dimension of each lobe is 5 into 3 into 2 centimeter. The length of isthmus is 1.25 centimeter both in vertical and transverse diameter. The thyroid gland is usually larger in females due to two physiological reasons or factors, which are menstruation and the pregnancy. By these two factors, females usually have a enlarged thyroid gland than the males. Now coming to parts and feature of thyroid gland. Thyroid gland is S-shaped gland of vertical right and left lateral lobes and a horizontal isthmus connecting them across a midline. Sometimes a small pyramidal lobe projects upward from the isthmus, usually to left of the midline. Now the pyramidal lobe is connected to hyoid bone by a fibromuscular band, and this fibromuscular band is called levator glanduli thyroidi. Now coming to capsules of the thyroid gland. As you can see the diagram, this diagram represents the capsule of thyroid gland. True capsule, venous plexus, false capsule, and the plane of cleavage. You can also see the thyroid veins. So coming to capsules of thyroid gland, basically there are two types of capsules: inner true capsule and outer false capsule. Inner true capsule formed by the condensation of fibrous stroma of the gland, and outer false capsule is formed by the splitting of pretracheal fascia. Now coming to difference between the prostatic capsule and the thyroid capsule. Deep to true capsule, thyroid venous plexus is present in thyroid capsule. So in this, venous plexus is present in deep to true capsule. But in case of prostate, the venous plexus is lie between the true and false capsule. Hence, it is a difference between the prostate capsule and the thyroid capsule. In thyroidectomy, which is the removal of thyroid gland, surgical removal of thyroid gland, for preventing hemorrhage, thyroid gland is removed along with the true capsule. So preventing the hemorrhage, thyroid gland is removed with the true capsule. In prostatectomy, the prostate gland is removed, leaving the both capsules behind. So this is the difference between the prostate capsule and thyroid capsule. In prostatectomy, prostate gland is removed leaving the both capsules, but in thyroidectomy, for preventing the hemorrhage, thyroid gland is removed along with the true capsule. Now coming to suspensory ligament of Barry. Now what is suspensory ligament of Barry? It connects the lobe to cricoid cartilage, and on the medial lobe, the false capsule thickens to form the suspensory ligament of Barry. Basically, its importance is that it will connect the lobes to the cricoid cartilage, and when the false capsule thickened at the medial lobe, it forms the suspensory ligament of Barry. Now what is thyroid tumor? Thyroid tumor is basically the enlargement of gland which extend backward because capsule is thin along the posterior border of lateral lobe, compressing the adjacent structure without forming a visible swelling on front of neck. So it will extend backward, and hence it will not form a visible swelling in front of neck in thyroid tumor. Now we are going to talk about the relation of thyroid gland. So first of all, we will see the relation of thyroid lobe, then we will see the relation of isthmus. So thyroid gland As we all know, it is a roughly pyramid gland which consists of apex, base, three surfaces and two borders. The surfaces are anterior lateral surface, posterior lateral surface, medial surface, and the borders are anterior margin and posterior margin. Now coming to the relation of apex, it is attached to the sternothyroid muscle, and apex is sandwiched between the inferior constrictor medially and sternothyroid laterally. Now coming to the base, it extends up to fifth or sixth tracheal ring, and it is related to inferior thyroid artery and recurrent laryngeal nerve. Base is related to inferior thyroid artery and recurrent laryngeal nerve. Now coming to anterior lateral surface or superficial surface, or it can also be called as lateral surface. It is convex in shape and it is related to three stap muscles which are sternothyroid, sternohyoid and superior belly of omphoid. Now it is also related to anterior border of sternocleidomastoid which overlap inferiorly. Now the medial surface of thyroid is related to cerebral structure, which are two tubes which are trachea and esophagus, two muscle inferior constrictor and cricoid thyroid, two cartilages cricoid and thyroid, and two nerve, extralaryngeal nerve and the recurrent laryngeal nerve. So now coming to relation of posterior lateral surface, it is related to carotid sheath, which contents are common carotid artery, internal jugular veins and vagus nerve. Its contents are basal carotid sheath. Now coming to anterior border, it is thin and separates superficially and medial surfaces. It is related to anterior branch of the superior thyroid artery. Now coming to posterior border, it is thickened and rounded and it separates the medial and posterior surface, and it is related to longitudinal arterial anastomosis between the superior and inferior thyroid artery and the parathyroid gland. Now coming to relation of isthmus, it presents two surfaces, anterior and posterior, and two borders, superior and inferior. Anterior surface will have strap muscles which are sternohyoid and sternothyroid, and it is also related to anterior jugular veins. Now coming to posterior surface relation of isthmus, it will be related to second, third and fourth tracheal ring. Superior surface will be related to anastomosis between the anterior branches of two superior thyroid arteries. Now inferior surface, along the border inferior thyroid vein emerges and thyroidea ima arteria when present enters. So this is the relation of isthmus. Now coming to arterial supply of the thyroid gland, as you can see the diagram, this is the thyroid gland and this is the artery supply. Basically thyroid is supplied by superior thyroid artery, which is a branch of external carotid artery. As you can see in the diagram, there is superior thyroid artery. It is a branch of external carotid artery. At apex, it divides into anterior and posterior branches. It supplies upper 1/3 of the lobe and upper half of the isthmus. Now coming to inferior thyroid artery, it also supplies the thyroid gland and it supplies the lower 2/3 lobe and the lower half of isthmus, and it is a branch of thyrocervical trunk from first part of subclavian artery, and it basically supplies the lower 2/3 lobe and the lower half of the isthmus. Now coming to the another blood supply, which is thyroidea ima artery. In 30% cases, branch of the brachiocephalic trunk, which is formed by the arch of aorta and accessory thyroid artery, which arises from the tracheal and the esophageal arteries. So now as you can see this diagram is a variable relationship between the recurrent laryngeal nerve and the inferior thyroid artery. You can see the inferior thyroid artery and you can also see the recurrent laryngeal nerve. In this, it is passes backward to the inferior thyroid artery. In this, it passes at above the inferior thyroid artery. In this diagram, it loops the inferior thyroid artery. So these are the different locations of the relation between the recurrent laryngeal nerve and inferior thyroid artery. Coming to venous drainage of thyroid gland, there are superior thyroid vein which drain into internal jugular vein, and then there will be the middle thyroid vein which drain into or end into internal jugular vein, then inferior thyroid vein which drain into left brachiocephalic vein, and the thyroid vein of Kocher will drain into internal jugular vein. As you can see the diagram of venous drainage in the thyroid gland, the superior thyroid vein, the middle vein, the inferior thyroid vein and the thyroid vein of Kocher's, they basically drain into internal jugular vein, but the inferior thyroid vein will drain into left brachiocephalic vein. This is the right brachiocephalic vein whose branch is internal jugular vein. These three, superior thyroid and then middle vein and then thyroid vein of Kocher's, will drain into internal jugular vein. However, the inferior thyroid vein will drain into left brachiocephalic vein. Now coming to lymphatic drainage of thyroid gland. So thyroid gland will consist of two groups, upper group and lower group. Upper group consists or drain into prelaryngeal and upper deep cervical or jugulodigastric lymph node, and lower group will consist of pretracheal and lower deep cervical lymph node along with the recurrent laryngeal nerve. So lower part of isthmus also drain into the retrosternal or brachiocephalic node lying in the superior mediastinum. Now coming to nerve supply of the thyroid gland. The nerve supply of thyroid gland is through sympathetic supply and parasympathetic supply. Sympathetic supply is derived from the superior cervical sympathetic ganglion, middle cervical sympathetic ganglion, inferior cervical sympathetic ganglion. Basically sympathetic supply occurs by middle one. Parasympathetic supply will derive from the vagus and recurrent laryngeal nerve. Now coming to microscopic or histological structure of thyroid gland. So as you can see, this is the microscopic structure of thyroid gland, in which there are follicular cells, parafollicular or C cells, blood capillaries, and thyroid follicles. Now thyroid gland will consist of two types of secretory cells, which are follicular cells, which are spherical thyroid follicle, and they are cuboidal epithelial cells, and secrete two types of hormones. The hormones are T3 and T4. T3 is triiodothyronine and T4 is tetraiodothyronine or thyroxine. These hormones are essential for the hormonal growth and skeletal nervous growth. And the second cell or group of cell is parafollicular cells or C cells. It lie between the basal membrane and the follicular cells, and some of them lie in the follicles also. They secrete the hormone thyrocalcitonin or calcitonin, which will play opposite role of parathormone, and they will play an important role in calcium metabolism, because they will decrease the calcium level in the blood by increasing the rate of excretion of the calcium and by deposition of calcium into the bones. So hence they will decrease the blood calcium level, and they will act opposite to parathormone. Now coming to development of thyroid gland. Follicular cells is developed from the median endodermal thyroid diverticulum in the primitive pharynx. Parafollicular cells develop from ultimobranchial body, which is fifth pouch. Fibrous capsule and connective tissue is developed from the surrounding mesoderm. So these are the steps. First of all, there will be foramen cecum and endodermal thickening. Then there will be formation of thyroglossal duct. Then there will be the formation of bifield lower end of thyroglossal duct. Then it will help to form the thyroid gland developing from thyroglossal duct. Thyroid gland will form by the help of thyroglossal duct, and there will also present of ultimobranchial body, which will help to develop the parafollicular cells. So it will finally form the thyroid gland, and the remains of thyroglossal duct will also be seen in the thyroid gland. This is the pyramidal lobe, this is the lateral lobe, this is the remains of thyroglossal duct, and this is the isthmus. Now thyroid follicle cells vary from one to each other on the basis of secretory phase. So they are basically three secretory phase. Normal resting phase, in this its lining epithelium or its epithelium will be cuboidal. In hyposecretory state, it become flattened or squamous epithelium cells, and in hypersecretory state or active state, it become lining follicum will become columnar. So these are the three stages at which the cells shapes changes, like in cuboidal, squamous, then columnar. Now coming to congenital anomalies or developmental anomalies of the thyroid gland. First there will be agenesis of the thyroid, incomplete descent of the thyroid, lingual thyroid, median thyroglossal ectopic thyroid, lateral aberrant thyroid, persistent thyroglossal duct, thyroglossal cyst, and the thyroglossal fistula. Now what is ectopic thyroid? Thyroid gland location at abnormal position anywhere along the course of thyroglossal duct is called as ectopic thyroid. It is of basically mainly two types: lingual thyroid, which is at the base of the tongue, or suprathyroid, retrothyroid, and infrathyroid, which is above, behind, or below the hyoid bone. So this is the ectopic thyroid. Now coming to some disorders related to thyroid gland, like goiter. Any enlargement of thyroid gland except that during the menstruation and lactation is called goiter, and can be through the hyper or hyposecretion of T3 and T4 hormones. Hypothyroidism. Cretinism occur in children, and myxedema occur in adult. Hypothyroidism. In case of hyperthyroidism, it presents the tachycardia, tremors, and systolic burn. It will finally increase the BMR. Now coming to simple or puberty goiter. It is the enlargement of thyroid gland without the signs of hyperthyroidism. It occurs due to the deficiency of iodine in the diet. Simple goiter occur at the age of puberty, so hence termed as puberty goiter. So puberty goiter is the deficiency of iodine, due to which the enlargement of gland occur at the puberty. Now coming to effects of massive enlargement of the thyroid gland. So what are the effects? The thyroid gland can expand backwards or downwards, and it have the three character pressure symptoms are dyspnea, difficulty in breathing due to the pressure on the trachea, dysphagia, difficulty in swelling due to pressure on esophagus, and dysphonia, which is the hoarseness of the voice due to the pressure on recurrent laryngeal nerve. Now what is retrosternal goiter? Downward expansion behind the sternum is called the retrosternal goiter. It can compress the trachea, causing dangerous dyspnea. Dyspnea is difficulty in breathing. Now what is thyroidectomy? It is the removal of thyroid gland with its true capsule. Surgical removal. What is subtotal thyroidectomy? Posterior parts of thyroid lobes are left behind. This is done to avoid the risk of removal of parathyroid gland, leading to hypoparathyroidism. Now coming to Bignon's tumor, may compress or displace the neighboring structure where the malignant growth tends to invade the surrounding structure. It is called Bignon tumors. Now explain anatomically why superior and inferior thyroid are important to neck surgery. So the superior and inferior arteries are important to the neck surgery because of parathyroid gland are closely situated with these arteries. So these arteries act as a key to approach the superior parathyroid and inferior parathyroid gland into operation, thyroidectomy and parathyroidectomy. So that's why they are important in the surgery. Explain anatomically why in thyroid surgery the inferior thyroid artery should ligate some distance to the lateral lobe of the thyroid gland. Okay, because the base of the thyroid gland extends up to 5th and 6th sixth ring of the trachea, and it is related to loop of inferior thyroid artery and recurrent laryngeal nerve. As we already seen the diagram, the nerve prevents a variable relation with the artery, therefore sometimes it passes in front or behind the loop or between the division of artery. So a ligature of inferior thyroid in the thyroid operation should be applied away from the gland to avoid the injury to nerve, because the nerve is related to the artery. Now explain anatomically why thyroid gland moves with the swallowing. Thyroid gland is invested within two layers of peritractal fascia, which is attached to the cornua of the thyroid bone and thyroid cartilage. That is why the thyroid gland moves up and down during the swallowing. Now coming to thyroglossal cyst or fistula. It is a cyclic remnant of the thyroglossal duct. Cyst may occur at the edge point along the thyroglossal tract. They occur commonly in the region below the hyoid bone. Such cysts occupy the midline and develop as a result of persistence of a small amount of epithelium that continues to secrete the mucus. As the cyst enlarges, it is prone to infection and it should be removed surgically. Since the remnant of the duct often transfers the body of the hyoid bone, this may have to excise and also to prevent the reoccurrence. Why thyroglossal cyst always in the midline of the neck? So it is a cystic remnant, we know, of the thyroglossal duct and may light at any point in the migratory pathway of thyroid gland. Therefore, the base of the tongue to the body of the hyoid bone, so thyroglossal cyst near the midline of the neck. This is the reason. Now, explain why hoarseness of voice may develop following thyroid operation. Terminal branch of inferior thyroid artery are related to recurrent laryngeal nerve on each side of the thyroid gland. Damage to external laryngeal nerve during thyroidectomy operation result in the inability to tense the vocal cords and the hoarseness of voice is produced. So this completes our video on today's topic of thyroid gland and its development. I hope you like this video. If you like this video, then don't forget to subscribe to my YouTube channel, which is MBBS Studies with Rishabh Singh. Thank you.